Dear all, Namaste. Today, I shall be discussing about oral submucous fibrosis. This condition is very prevalent in Terai belt of Nepal, especially eastern Terai region. This is defined as chronic debilitating disease of oral mucosa characterized by inflammation and progressive fibrosis of lamina propria and deeper connective tissues, followed by stiffening of an otherwise yielding mucosa, which results in difficulty in opening the mouth. This is most prevalent in the buccal mucosa, but it may be found in other area also, maybe hard palate, soft palate, in the uvula, and part of the posterior pharyngeal wall. This condition is important because it has malignant potential, and the condition may convert into malignancy. By definition, this causes inflammation of the lamina propria and deeper connective tissue, called as submucous fibrosis. What is the basic pathophysiology? This is a multifactorial disease which is caused due to erica node chewing, which is the most important predisposing factor, followed by ingestion of chilies, genetic and immunologic processes, and nutritional deficiencies. Erica node chewing and ingestion of chilies are common in our setup, basically in the southern part of Nepal in Terai region. So this may be more prevalent in the Terai part of Nepal due to these conditions also. What is the reason for oral submucous fibrosis to be caused by excessive erica node chewing? The main factor in oral submucous fibrosis is ericolin, which is the active alkaloid found in betel nuts, that leads to oral submucous fibrosis by stimulating fibrogenesis, increased fibroblast formation, increasing collagen synthesis by fibroblast. Again, there will be increased collagen synthesis and collagen accumulation leading to white color of the submucosal layer and decreasing collagen degradation. That means increasing collagen synthesis along with decreased collagen degradation leads to oral submucous fibrosis. Ingestion of chilies has been found to cause hypersensitivity reaction with the mucosa submucosal layer that leads to oral submucous fibrosis. In the early stages of oral submucous fibrosis, the patient will have irritation of the throat or oral cavity, which is aggravated by taking the chilies. Increased frequency of HLA-A10, B7 and DR3 in patients with oral submucous fibrosis has been associated with genetic and immunologic processes, and nutritional deficiencies like iron deficiency anemia, vitamin B complex deficiency, and malnutrition are associated with oral submucous fibrosis. In this context, we should understand that repeated wound healing and wound formation leads to increased fibrosis that also leads to oral submucous fibrosis. These conditions lead to delayed wound healing. What are the clinical features? How does the patient present to us? The symptoms are oral pain and burning sensation upon consumption of spicy foodstuff in early stages. A person who is used to take tobacco, pan parag, erica nut comes to us with history of oral pain and burning sensation. We should think of early stage of oral submucous fibrosis. There shall be dryness of mouth and change in gustatory sensation because there will be oral submucous fibrosis, and there will be decreased production of the saliva also from the minor salivary glands. There will be impaired mouth movements like eating and blowing because of submucous fibrosis. When it is severe, there will be problem to open the mouth, usually due to the involvement of the palatoglossus fold near the anterior tonsil pillar. Sometimes the patient complains of decreased hearing, which is due to stenosis of the eustachian tube, and patient occasionally may have nasal intonation of voice because the uvula will be short and ball-like. What are the signs? That means what we see on patients with oral submucous fibrosis. There are certain stages. The first stage is stomatitis. There will be erythematous mucosa, vesicles, mucosal ulcers, and petechia in the oral cavity. Second stage, there will be blanched floor of the mouth and soft palate with decreased mobility that may lead to stiffness or trismus. When there is blanching of the floor of mouth and soft palate, we should think that patient is having oral submucous fibrosis. The tonsils also will be blanched and small. They will be atrophic, and there will be shrunken and bird-like uvula, small uvula which is shrunken and bird-like. We should suspect there is fibrosis. So the uvula gets fibrosed, tonsils get atrophied and blanched, and the oral mucosa itself may be white in appearance, that is in fibrotic stage. And sequelae, there will be leukoplakia, speech and hearing deficits, and the patient may develop carcinoma also. In this picture, you will be seeing the oral submucous fibrosis. See, this is the hard palate, which is whitish appearance, and uvula is also white. And in this case, this is the late stage. The patient is having ulcer here, there will be scar or band, fibrous band, and this is a very important thing. There is a scar band in the anterior tonsillar pillar, that is towards the palatoglossal fold. This leads to trismus. You can see here, this is fibrosis, which leads to trismus. Then how to go for treatment? Treatment can be medical and surgical treatment, and treatment of sequelae also. Steroids are the very important medicines for treatment of oral submucous fibrosis. Although they have short-term improvement only, weekly submucosal injection of dexamethasone 4 mg or triamcinolone 40 mg can be given. So with that, patient should feel better after 6 to 8 weeks. Topical application of betamethasone cream 0.05%. Topically 6 hourly can be given for 3 weeks, can be given for longer time also. As we told, steroids are the strong anti-inflammatory agents, so they decrease the inflammation and lead to improvement in symptoms, but maybe short-term only. Topical or intralesional hyaluronidase can be used, which lowers the viscosity of the intracellular cement substance and decreases collagen formation. One of the causes for oral submucous fibrosis is increased collagen synthesis. So when there is decreased collagen synthesis, the patient will feel better. The steroid plus hyaluronidase injection sites are towards the lateral aspect of the oral pharynx, basically towards the palatoglossal fold. So this is the area where there will be maximal fibrosis, and that also leads to trismus. Therefore, these are common sites to be injected. In early stages of injection, there will be no bleeding, but as in later stages, there will be bleeding from the injection sites, which is good for us. Steroids plus topical hyaluronidase used together provide better long-term results than either agent used alone. Submucosal administration of aqueous placental extract, which is anti-inflammatory, which prevents and inhibits the mucosal damage. Submucosal administration of aqueous placental extract can be performed, which is a strong anti-inflammatory agent that helps to prevent the mucosal damage. So there will be less mucosal damage and there will be early wound healing process. Intralesional injection of interferon also can be tried, interferon gamma basically, which helps by immunoregulatory effect and by antifibrotic cytokine production. There will be decreased fibrosis or there will be fibrinolysis, but its role is questionable. It has not been tried in many centers till yet. Pentoxifylline 400 mg 3 times a day for 4 to 6 months can be tried, which provides oxygenation to the tissues. When there is fibrosis, there will be decreased oxygenation to the tissues, and pentoxifylline will lead to increased oxygenation that leads to improvement in symptoms. If medical treatment fails, then patient has to undergo surgical treatment. The indications for surgery are the patients with severe trismus who cannot open the mouth, and biopsy results revealing dysplastic or neoplastic changes. So when the patient is going to have cancer or maybe dysplasia, so we have to treat the condition, we have to remove the disease so that patient won't develop cancer in the oral submucous fibrosis. Different surgical procedures are simple or laser excision of fibrous band that leads to increased mouth opening, split thickness skin grafting following bilateral temporalis myotomy, coronarectomy, or resection of the fibrous bands again leads to removal of the oral submucous fibrosis plus to reduce the trismus also. Next is excision of fibrotic tissues and covering the defect with fresh human amnion or buccal fat pad graft has been tried. Fresh human amnion contains many micronutrients for the wound and there will be increased vascularity which leads to wound healing. Surgical excision of bands and submucosal placement of fresh human placental graft can be tried. Surgical excision of the bands and submucosal placement of fresh human placental graft can be tried. Again, placental graft also helps in revascularization, increased vascularity, and wound healing. Certain flaps like nasolabial flaps, lingual pedicle flaps, platysma flaps also can be used to treat oral submucous fibrosis. Our basic aim in surgery is to remove the disease and to prevent cancer formation and to close the defect by different surgical procedures. At the outset, the most important thing leading to oral submucous fibrosis is the erica nut chewing. So our patients have to avoid the habit of taking erica nut or pan parag also, and tobacco and smoking along with alcohol. They are all risk factors for oral submucous fibrosis along with carcinoma of the oral cavity. If you like my video, please subscribe my YouTube channel, Dr. Krishna Koirala. I'll be presenting more videos like this. Thank you very much.